my great pleasure to introduce Dr. Alfred Sacchetti for his talk, The Pediatric Airway. So if everyone could please help me in welcoming Dr. Sacchetti.
Thank you. That's very nice. Actually, I'm thrilled that you guys are all here. I figured we'd have 5 people. We can go to the bar and do this talk. But okay. If you've ever seen, there's a volume on that one, if you can bring it up. If you've ever seen this child, you probably know just how tight your shorts can get. Kids with airway problems are not uncommon in the emergency department, and one of the things that you have to tell emergency physicians over and over again is, you've got this, you understand this, this is your specialty. Everything you do with an adult airway problem translates to a child. And we're going to prove that at this talk. All right, so what are you trying to do? Well, the first thing you're trying to do is oxygenate the kid. Okay, I'll give you that. And then ventilate them, but not as much. You can let a kid get a little hypercarbic without too much problem. And we certainly do it with asthmatics, permissive hypercarbia. So I'm not too worried about that, but the oxygenation they're a little bit more sensitive to. So the other thing is, what are you treating? Well, sometimes you're treating obstructions and foreign body masses, edema, inflammation, even anatomic. This is actually the epiglottis of one of our docs. His son was born with a stricture, and I have no idea how this kid breathed through that. There's got to be an opening there somewhere. Either that or he was absorbing oxygen through his skin. But they actually had to go in and remove the stricture to get that thing to open up on him. The other thing is there's lower airway problems, and these are all the alveolar problems. And then there's neuromuscular things, toxicities, kids with overdoses, fatigue, and that's the main thing you're going to see with neuromuscular is kids are going to just get tired breathing so hard. And then some neuromuscular pathology, the kids with the various muscular dystrophies and whatnot. So let's talk about obstructions. Well, the first thing is you can remove it. If the kid swallowed a big sponge bowl, you can go in there. The key to this is make sure you've got the pediatric-sized McGills in your airway cart. You should have 1 or 2 sets in there because the time to figure out that you need it is not when you need it. You want to make sure that it's in there to begin with. You can shrink it. Epinephrine works just fine. Do not use racemic epinephrine. I have no idea why that still is hanging around in 2018. Regular good old variety 1 to 1,000, which is now they changed the name of it, the concentration of it, but it's a regular garden variety sub-Q epinephrine. 3 cc's of it is the perfect dose for every size kid. Will shrink the edema just fine. So whether you have croup or whatever you have, this is all you need. Don't go looking for that racemic and then trying to figure out the dose of it. And you can bypass it. This is a transtracheal catheter. I have no relationships with any of the companies, but I'm going to talk about a lot of equipment here. And just because I mention it doesn't mean that they're the only ones who make it. They just happen to be the ones who I have pictures of. This is actually made by Cook, and you puncture the trachea with this from the outside, and you can ventilate the child. The problem is you can oxygenate it, but you can't really ventilate. You can put air in, but you can't get it out. It's difficult to exhale through that. And this is another device that's now on the market. And what this does is when you push the button, it'll push air into the transtracheal catheter. But then when you take your finger off, it shoots a stream of oxygen across the top of the catheter, which by the Venturi effect basically drops the pressure and will actually suck the air back out. So you can ventilate the kids. You can control both the oxygen and carbon dioxide with this device. Now, if you're talking about the lower airway, that's a bit more of a problem. Over here, you've got pretty much a normal-looking lung, and you can figure that any gas that you have in those open spaces is going to be able to diffuse into the capillaries pretty easily. On the right side, you've got an edematous lung. You've got a lot of white cells in there, whether it's a pneumonia, whether it's an inflammatory process of another nature. It's going to be difficult to get the gas to go from here into the capillaries. So what you're going to have to do is you're going to have to come up with a better way to get that gas to transfuse and get into the blood. All right. If you look at oxygenation and ventilation, you can kind of squash everything down into a formula. And the things that are in red are the things we can control. The things that are in black we can't. So your ability to oxygenate and ventilate a child is in relation to the length of the airway, which we can't control, the viscosity of the gas going through there, which we can control. That's the N here. The radius of the airway you can control. We can bronchodilate people. We can shrink edematous airways there. And then the difference in the oxygen concentration between the alveoli and the blood, which we can control. and then the pressure, so the change in pressure. So if you look at the first part of that, the right side of that equation, the viscosity we can control. We can put somebody on heliox, it'll decrease the viscosity of the gas they're breathing and make the gas move in and out easier and hopefully exchange a little bit better. We can change the diameter. We can get bronchodilators, steroids, and even shrink the distance that the gas has to diffuse across when you get down to the alveoli. When you get over here to the other side of this equation, this is where you're talking about the non-invasive airway stuff. This is where you can play with the gas gradients. If I can get a higher concentration of oxygen down into that alveolus, I can drive it into the red blood cells a little bit easier. If I can keep the alveoli open longer, it gives me more time for the gas to diffuse into the alveoli. And then the flow dynamics of moving things in and out with the velocity that I can get the gases in and out of the child. If you're looking at non-invasive ventilation, there's two things out there. There's high-flow nasal cannulas, which are now migrating to high velocity, because it turns out it's more the velocity of the gas than the flow of the gas that makes a difference. And then non-invasive positive pressure ventilation, either BiPAP or CPAP, whatever you happen to have in your department. Okay. How does a high-flow nasal cannula work? And why should it work? And the answer is they didn't understand how this worked until they figured out why these kids didn't suffocate. Okay, if you look at a newborn, here's what happens. A newborn, so these guys each weighed about 3,000 grams. So when you look at them, the extrathoracic dead space, this is the part of the airway outside the thoracic cavity, so pretty much from the epiglottis up through the tip of the nose, is about 3 milliliters per kilogram. Okay, so that's a pretty significant amount of space there. And all the gas in there doesn't exchange any oxygen. It moves in and out with respiration, but doesn't allow you to oxygenate or ventilate. So in these guys, that's about 9 mLs. The intrathoracic dead space is about 1 ml per kilogram. That's the trachea and some of the major bronchi. So that's another 3 mLs. So the total dead space, the amount of gas-containing material in these kids that's not doing any gas exchange is 12 mLs. Their tidal volume is 15 mLs. So that means they really have an effective tidal volume of 3 mL. So these kids are trying to live on 3 mLs of gas exchange. They should asphyxiate within 10 minutes. Okay? And the fact that all of you are here tells you that you didn't asphyxiate when you were born. And the reason they don't is because they breathe very fast. Everybody always thinks a kid breathes fast because they're higher metabolism. That's not the case. That's not why a neonate breathes fast. They breathe fast because in their nose, the way their nose is designed, and the reason they're obligate nasal air breathers, is they create a lot of turbulence, a lot of vortices up in their upper airway. And what that allows them to do is that allows them to mix the gas that they exhaled with the new gas coming in. Because if they don't do that, they're not going to get any fresh oxygen in there. They're just going to keep rebreathing the gas they just exhaled out. And so the way they do that is by just making the gas exchange quickly and washing out as much of the dead space in their nasal pharynx and posterior pharynx as they can. This is what the high-flow nasal cannulas do. The high-flow nasal cannulas are designed to basically mimic what neonates do. And what you're looking at is a dead space washout. So what you're trying to do, all these little vortices that you create here, basically wash out the gas that you exhale and allow you to breathe in whatever fresh gas your cannula is putting in. This is why the cannula is the most important part about this. Everybody gets all excited about the high flow and the oxygen and the humidity in it and whatnot. That's not the key part. The key part of a high-flow nasal setup, and this is why they're changing to high velocity, is you've got to duplicate this washout. And it doesn't work if you just put a regular catheter in there. The catheter has to be specifically designed to create these vortices in there. So what you're trying to get rid of is the last gas out, first gas in. So when I exhale, what's stuck in my nasal pharynx is a PCO2 of maybe 40 and a FiO2 of maybe 13%. I'm going to rebreathe that in, but I've got a big enough tidal volume that I'm going to, once I get past about 150 cc's, the rest of the gas I pull in is going to be fresh air. These kids can't do that, so this is what they duplicate. The other things it does is it does a couple things. One is when you put these catheters on and you set the flow high enough, they can't breathe in anything but the gas you're giving them. So if you put them on 100% and you set the flow at appropriate level, the velocity going in there, they can't outbreathe that. They can't pull in air from the outside. If you put 100% non-rebreather on somebody, they suck in a lot of room air. Kids can't do that. You can't do that if we set this on you and set it at the appropriate settings. So number one, you're going to maintain, you can drive their oxygen up as if they were intubated with 100% oxygen. Then if you do that, it makes the respiratory muscles more efficient. You can mix the gases, and you can condition the gas. It turns out we spend a lot of energy trying to warm what we breathe in and moisturize it. Well, the gas that you're breathing with a high-flow nasal setup is both moisturized and humidified and heated, so that the gas you're breathing in and out is already at the ambient temperature and humidity that the body can use it most effectively. Most people don't realize is that most of the resistance to your airway is at the tip of your nose. The introduction to the airway is there. These cannulas are designed to go just past there, so you reduce 50% of the resistance in breathing. So it's easier for the kids to breathe in and out. They don't have to overcome that resistance there. There's a very mild pressure effect. Everybody likes to call this, oh, mini BiPAP. That's not how it works. It's a washout effect. It's a flow effect. It's nothing to do with pressure. We're going to talk about that in a little bit. Okay. So the high-flow nasal cannula, it's an open system. The cannula is going to be less than 50% of the nares. It's conditioned gas, and they're really high flow, so you can't overbreathe it. You're always going to be able to deliver whatever you set your machine at, the kid's going to take in there. They're moving now towards high velocity because it more emphasizes that the cannulas are designed to get stuff back there quickly and create the turbulence rather than just the flow. And if you look at articles on high-flow nasal cannulas in kids, you've got to be careful what you're reading, because not all of the systems do this. Some systems are just like what they call a ramjet, which just gives you high flow and high humidity in the gas that you're putting in there, but it doesn't do any of the washout effect. And those are the studies, when you read them, and they say it had no beneficial effect. When you look at it, you see that, oh, they really didn't use a high-velocity cannula. They just used a regular cannula. All right, when you do this, the way you do it is the company described it this way. You set the flow and you adjust the O. So what you do is you tell whoever your respiratory therapist is, I want this kid on 18 liters a minute, start him at 100%, and then adjust it down, the FiO2 down. It's a very dynamic process. This is not just set it and walk away. This is a lot of interaction between you, the respiratory therapist, and the patient. And what we'll generally do in our shop is give them a starting point. Let's start at about this flow. Let's start about this oxygen. And you titrate it to get the child's respiratory rate down or the adult's respiratory rate down. And I want to keep their oxygen saturation at 93%, 94%. You're not shooting for 100%. 94%, 95% is perfectly fine for these kids. In setting your first guess at the flow, it's pretty much, if they're less than 1 year of age, it's about 2 liters per kilogram per minute. A child over 1 year of age, it's about 1 kilogram per minute. And then the adults, it's 0.5 liters per kilogram per minute. You think about it this way, your average adult's probably going to start at 30 to 40 liters per minute on this, and you can just back it down. If you like formulas, here's the weight-based formula. It's 2 liters per kilogram per minute for the first 10 kilograms, and then a half liter per kilogram per minute for every additional kilogram. I just find it easier to start the kids under a year of age at somewhere around 1.5 to 2 liters per kilogram per minute. This is a kid with bronchiolitis, and you can see he's working pretty hard. This is about 10 minutes after he's put on the high-flow nasal cannula. When it works very, very quickly. Because the kid's effort of breathing, they're not trying to get all this gas in and out. You wash out what's in their nasopharynx, and all of a sudden you increase the efficiency of their tidal volume by about 30%. All right. Non-invasive positive pressure ventilation also has a role in kids. This is a pressure-driven situation. So now you're not looking at flow. It's a closed system, and now you're modulating the pressure these kids are breathing in with and breathing out against. You can either use a BiPAP, CPAP, whichever you like, whichever your hospital decided on. Both of them will work equally well. And the reason this works is what you do is you stent the alveoli. So by breathing out against the pressure, you can keep alveoli open. If you've got a diseased alveolus, it's pretty much destroyed the surfactant in there. And so each time you exhale, it's going to collapse, and when you breathe in, it's got to open up again. It takes a lot of work to open up a diseased alveoli, but when you put them on the positive pressure systems, it stents that alveoli open. So it never collapses. It stays open during inspiration and expiration, and it extends the time when you could exchange gas off of that really edematous, maybe inflamed alveolus, and you can get the gases in and out a little bit easier. It decreases the work of breathing, and One of the downsides to it is it will decrease venal cable return. So you got to make sure these kids are hydrated. So don't hesitate to put a lot of fluid into these kids if you're going to put them on a positive pressure system. The way I look at it is like this. If the child's breathing and they're really working, they're moving gases, I can put them on the high flow nasal cannula. Because if they're going to move the gas in, I'm just going to make the gas they're moving in and out much more efficient. So that's over here. So sometimes they just get a little bit of oxygen. Now they're working pretty hard. I put this on. And what I'm going to see very quickly with these kids is their respiratory rate's going to drop. They're going to get much, much more comfortable very quickly. And then I know it's working. And everybody says that. They'll cough a lot because you'll loosen up all their secretions with the humidity. As they start to get tired, so now this is one over the respiratory effort, they need some help in moving the gas in and out. And now I'm moving towards the non-invasive pressure ventilation. So these are the kids that are going to need some BiPAP or CPAP. They need something to help them move the air in and out because they're getting fatigued. And then as that begins to fail, now we're on to endotracheal intubation. In terms of neuromuscular stuff, toxicity, obviously, if they've got a specific toxin with an antidote, the Narcan type things, you can just give them that and that'll start their breathing. The others are if they start to fatigue, they've got the muscular dystrophies, they've got some other neuromuscular type of problem, or they're just exhausted from working really hard, they're an asthmatic. Those are the ones that are going to do better with the BiPAP, the CPAP systems, because it helps them bring the gas in, it stents them when they're breathing out, and the neuromuscular pathology, the things that have specific antidotes that only the pediatric inborn error metabolism folks know about, those you just contact and you use the things like myasthenia gravis and whatnot. All right, pediatric intubations. Okay, I have no idea why people believe they are not just small adults. They are small adults. The head is above the shoulders, the eyes are both in the front, there's a nose in between the mouth, and it's not like a 3-week-old is a tadpole, and then when they turn 18, they turn into a frog. It's not like that. They are small adults. The only difference is they're easier to intubate. And they are. They're much easier to intubate than an adult. You don't have infants with no neck. You don't have infants that have no jaw. They're pretty much easier to intubate. Now, there's some congenital anomalies, but for the most part, they're easier to intubate. The other thing to remember is you don't want to procrastinate. This is not the thing where, the kid's getting tired, they're looking worse, you're upping the oxygen, you're playing with all these non-invasive things, and you can't get them to turn around. Take advantage of the fact that they still have some reserve left. So if this is a kid that's getting tired, and I just know they're not going to turn around, there's no advantage to me to keep trying and trying and trying. If I start my intubation here, okay, their pH isn't bad, it's the world's most god-awful intubation. You're throwing ET tubes around. People are running away from you. It's the type of thing that takes you 5-10 minutes to get the tube in. You bag the kid a couple times. But when you get the tube in, they're here. They've still got some reserve left. If you wait until that kid's just got that last possible agonal breath, you're starting here. They're acidotic. They're hypoxic. They're going to get much worse during the apneic period when you go to do your intubation, and when you finally get the tube in that god-awful intubation, somebody's doing CPR for you. So don't procrastinate. This is not the thing where you want to try and get them to just stretch out and sign out to the next coming doc. This is one you got to grab up early, and you'll know. And what I always like is the pediatric pulmonologist always say, well, we like to wait till the last possible minute to do the intubation in an asthmatic. It's like, that's true. You're in a pediatric ICU with 7 people in there, all of whom can manage the airway, and all of whom are free to manage the airway. The ER doc's in a community ED, the only person there who can manage the airway, and they're also managing the rest of the department. If they recognize that the kid's failing, that's the time to do the intubation. You can pull the tube out when they get to your shop if you don't like it. I always like it, but one thing that really always made me very upset is they talk about, because every time we intubate an asthmatic or bronchiolitic, they go, well, why'd you do that? It's like, well, we didn't want to deliver them doing CPR, but they say, well, all the data says you should wait till the last minute. I said, if you look at the data, the deaths from asthma are going up and up and up. So your concept of waiting till the last minute obviously isn't affecting the mortality of these kids. Maybe you guys ought to let the ER docs write these policies. All right. This is the obligatory slide that everybody has to show that says the epiglottis is a little bit higher in a child than in an adult. It's up around C1, C2 rather than C3, C4. But the thing about intubations is it's a process. And you know, these are the things you always hear about: your preparation, pre-treatment, the procedure, post-intubation care. The only thing to remember here is this is one of the things where it is worthwhile to have a checklist. You know, just have it printed, put it on top of your Airway card or something. The last thing you want to do is be halfway through the intubation and say, okay, you know, I've given my paralytic, you know, somebody give me the ketamine, and they go, oh, they're running to the pharmacy to get it. You know, that's not the time to realize that, you know, they used the last dose of it on some, you know, agitated psychotic patient and they didn't replace it. So you want to just kind of, this is worthwhile having a checklist. The equipment you need, don't reinvent the wheel. This publication is out there. It's in the Annals of Emergency Medicine. It's in the Journal of Pediatrics. There's a new version coming out probably, I think, November 1st. And it's pretty much the same as this one. But it's really nice because if you go through it, it's like, oh, geez, I never would have thought that I needed this size of this equipment or those types of things. It's just a nice thing to have. Give it to your equipment manager. Let them put all the things you need in the card. It's not bad. The other thing is you want to get the patient as oxygenated as you can. Okay, so your oxygenation, you're going to put them on 100% non-rebreather. I'm a big fan of the concept of 100% non-breather and the nasal cannula both. If you don't have the high flow setup, what you want to do is put regular nasal cannula on, crank it up as high as you can, put 100% non-rebreather on. When you paralyze them to do the intubation, you take the non-rebreather off, you leave the nasal cannula on. It's this concept of apneic oxygenation, the theory being that if you put enough oxygen in the posterior pharynx, what's going to happen is as the blood circulates through the alveoli, it pulls the oxygen out, that creates a negative pressure, and it's going to suck more oxygen in. And there's data out there that this tends to work. If you have a high flow setup, if you happen to have one of the high velocity setups, you don't have to put the mask on. Just put that on, and that'll suffice. And the nice thing about that is it's not in your way when you go to intubate them. You don't have to worry about taking the mask off. Equipment, like I said, you want to make sure you have all the equipment. This bothers me very, very much. I don't know how in 2018 anybody can do an intubation, an adult or a child, without one of these. This is an end-tidal capnometer. You can see the thing on the bottom. Each breath goes in and out. You can see the waveform. And yet I know university residency programs that still have that little doorknob that's supposed to change color, and that's how they tell whether the tube's in or not. How many people are going to be honest here? Do you think that doorknob's going to change color if you put it on this kid? You know, there's not enough, there's like 3 molecules of carbon dioxide coming out in each breath. It's not going to change color. And the other thing is, if you're sweating the intubation, there is nothing more reassuring than to see that thing jump up and down with 2 bags, you know, when you bag the kid a couple of times, to know that the tube's in the right place. So I really, really have to stress, you got to be doing your intubations with these things. Even our department, we've got one of the walls, got a new bank of monitors. All the monitors now come with this. And you can use it for procedural sedation, all the other things you like to use. All right. Direct laryngoscopy versus video laryngoscopy, pick your favorite, you know, whichever you want. They both work really well. All the studies show that there's no clinical difference. The video laryngoscopy gives you a better view of the glottis. You see that really nice, perfect view of it. But the direct, the old standard laryngoscope, is faster because you don't have to see that whole glottis. So most of you people in this room are pretty experienced. All you have to do is just get a glimpse of what the bottom of the glottis looks like in a couple of millimeters of the cords, and you know where to put the tube. But still, whichever you want, there's no difference. You probably should have both, but whichever you prefer is fine. Big debate now is cuffed versus uncuffed. The standard treatment is uncuffed cuffed tubes begin at 5 millimeters. Now the technology of the ventilators has gotten better. The technology for the tubes is getting better. You're seeing a lot of neonatal cuffed tubes. And with the neonatal cuffed tube, you can put a higher pressure on the ventilator. So that's a big thing. So if someone says, gee, we want to switch to cuffed tubes, that's fine. The only thing to remember is if you're using a cuffed tube, you tend to use one size smaller than the uncuffed tube when you go to do these things. Realistically, we're practical people. Use what you got. If you've got a cart that's full of uncuffed tubes, just use them. I mean, you know that you use only a handful a year. It's going to take you 3 years to use up the whole box. When you use up the whole box of number 3.5 tubes, go buy some cuffed tubes. But for the short term that we manage them in the emergency department, the uncuffed tubes will be just fine. All right, manual ventilation. This is something you want to buy. I have no financial interest at all, but this is a freaking amazing device. This is called the Neonatal, and what it is it's a way to ventilate the kids without using a bag valve mask. You can use it up to, they say to use it to 10 kilograms, we'll take it up much higher. It hooks onto your wall outlet. You turn this all the way up, and you can adjust the flow here, and then this is how you trigger it, and you adjust the PEEP. So what happens is you put this thing on somebody, and what you can see is that's just pointing out a bunch of stuff there, but you'll see when it take it off there. If you were to push the button down, you deliver the gas. So each time you push it down, you deliver a breath to the child. And what you can do is you can set the pressure that you're delivering it to. So if you want to do 25 millimeters of water, which is what most people do to start breathing on the child, you can do that. Whether you're using a bag valve mask or whether they're intubated, you're controlling the pressure that's going in. If you're trying to do it with if you're using just a plain mask, if you're trying to do it with a bag valve mask, am I squeezing too much? Am I not squeezing enough? And you've got, a lot of times you're getting ready to do the intubation. You've turned the bag valve masking over to a tech or to a nurse. They're not, sometimes they're not giving enough tidal volume. Sometimes they're giving too much. This makes it much easier. You're going to deliver the gas. You're going to see the chest exprise. You release it, goes away. The other thing is it will give you PEEP. You can set PEEP up on it as well. And this is what it looks like on a kid, and that's one of our techs. All they do is they push their finger down, ventilates the kid, they take their finger off, the kid exhales. Much, much more consistent breathing. Now, this is a kid that got intubated, and you can see the tubes down the right main stem bronchus, and they've got atelectasis everywhere, except for that right main stem. When they pulled the tube back, the kid got more hypoxic. And the reason was they're trying to ventilate all the lungs, and all of them were atelectatic. So we had to get PEEP into the kid and get the pressure up from the normal 25. So we just adjust it on the wall, and you can see that the PEEP's now set at 10, and each time he puts a breath in, it goes up to, you'll see it'll go up to about 30. And then no worrying about squeezing the bag. All he's doing is pushing his finger. This is what it looked like. This is after we pulled it back and adjusted the PEEP and adjusted the positive pressure. And then after we blew everything back up, we were able to drop it back down to 25/5. So it's a very, very effective device. Your techs can do it. You don't have to be bagging the kid. Otherwise, it's very difficult, either with an ET tube or a mask on, to try and bag to the right pressure. All right, straight versus curved. Curved is supposed to go in the vallecula. You lift. You guys all know this from the adults. A straight blade, you're supposed to go down, pick up the epiglottis, lift it up, and do it that way. Transition point somewhere around the age of 4. I've been able to do 2-year-olds with a curved blade with absolutely no problem. We're going to come back and visit that in a minute. In terms of medications, atropine, there's a number of randomized controlled trials that show that pre-treating with atropine has absolutely no difference in bradycardia, hypoxia, anything else. The problem is all those studies are done in the operating room with well-oxygenated kids under controlled conditions. In the emergency department, I give it. And the reason I give it is if I have a lot of trouble and I can't oxygenate the kid and I wind up stumbling down that pathway where the kid's getting hypoxic on me, they don't get bradycardic. They will be able to hold their heart rate a little bit better. And it's not that that makes a difference, but there's a kind of like a threshold point where once they start going down that curve towards bradycardia, it's really tough to bring them back. The other thing is a defasciculating dose of neuromuscular blockers. Don't give it. If you're intubating a kid and the kid's tired, they're going to stop. They're going to become apneic and paralyzed with that defasciculating dose of your depolarizing muscular blocker. Your induction agents, propofol, ketamine, remifentanil, methotrexate are your go-to agents. Propofol is very fast. Ketamine gives you some bronchodilation and will maintain your blood pressure. Remifentanil, most people aren't familiar with. It's very similar to fentanyl, only it's only got a 5-minute duration of action. So it's a drug you can give if you want it to wear off quickly, and methotrexate has pretty much been replaced by propofol in most places. Etomidate, midazolam, lorazepam, and fentanyl. A lot of people like Etomidate. It carries a lot of baggage with it. I'm not a big fan of it. If you like it, fine if it works for you. I'm not a fan of it. Midazolam's a little bit slow on the uptake. Lorazepam and fentanyl really aren't good drugs for induction agents. If you look at them, the fastest at the top, propofol, methylhexatol, ketamine are probably your fastest. A little bit slower is ketamine, a little bit slower is the remifentanil, and then you get down to the slower drugs. Drug-specific adverse effects, Etomidate's probably got the most. Hypotension, remifentanil is probably the worst there. In terms of your agents, whether you go rocuronium, vecuronium fan, or you're a succinylcholine fan, I'm a much more supportive of the rocuronium. I like it for a number of reasons. It's very, very fast. A lot of people think it's slow. We'll explain it's not. This concept of, if I can't intubate them, the succinylcholine will wear off, actually doesn't really hold true. And here's the truth with rocuronium. If you've got a fatigued patient, whether it's a child or an adult, when you push this drug, 1 circulation time, they are paralyzed. It doesn't take that 15 to 40 seconds that people say it takes. If you've got an exhausted patient, they go with 1 circulation time, they will be completely paralyzed. So be aware of that. This is not a drug you're going to push and it's going to take a little while to work. It's going to kick in immediately. So in those patients, it's faster than succinylcholine. It does require ongoing sedation. If you decide you don't like what happened, you can't manage the airway, you need to revert, you need this child to start breathing again, which really isn't what you want. You want them to stay down so you can do your rescue procedures. But if you decide you absolutely have to reverse this kid, you can reverse rocuronium in 3 minutes. So 3 minutes after you push it, you can give the reversal agent sugammadex. They will be completely reversed, have all their muscle tone back, and start moving and breathing again on their own. Okay? Succinylcholine, everybody says, well, it wears off in 10 minutes. It doesn't really wear off in 10 minutes. It wears off, it starts to wear off in 10 minutes, but it's a good 15 minutes before they have enough muscle tone to start breathing again. The problem is, if you couldn't figure out a way to oxygenate that kid for those 15 minutes, it's not going to do any good anyway. By the time it wears off, you're going to be doing CPR. So it's not really that advantageous. The other problem is it's one and done. So if you give it and it doesn't work, and now it's worn off, and now you've got a struggling kid who you're trying to do a rescue procedure on, it's not where you want to be. This is that combination, Etomidate, succinylcholine, which a lot of people like. If it works for you, fine. But these are all the bad things that happen with it. Etomidate lowers your seizure threshold. If you've got a kid with a head injury, the last thing you want to be doing is giving them a drug that causes seizures at the same time you're paralyzing them so you don't know if they're seizing. So it's not a good drug in that respect. There are risk factors. Both the succinylcholine will produce bradycardia and asystole. I have had it happen to me, which is part of the reason it leaves a bad taste in my mouth. Don't worry about hyperkalemia unless you have a dialysis patient. There's a bunch of other cardiac problems. Increased intracranial pressure. Both of these will increase your intracranial pressure. Everybody thinks Etomidate lowers it. It doesn't. It actually raises the intracranial pressure. Malignant hyperthermia. If you're really, really, really unlucky, it'll happen to one of your patients, but it's really not likely to happen. And then you wind up with all the other stuff. The adrenal suppression, everybody talks about it. It's not, as much as I dislike Etomidate, that's not a reason not to use it. Okay. You can intubate kids without paralyzing them. Okay, some of them you watch the neonatologist in the operating room. They just overpower the poor little guys. Not the way you want to go, but you can do that. Things that will help you. You can just give a kid a slug of ketamine, and one of the nice things to do is if you just give them ketamine, you can take a laryngoscope and look back there and go, oh, you know what? I can see things pretty well. I have no problem paralyzing this kid to make the intubation a little bit easier. Propofol, you can make anybody non-resistive to an intubation with enough propofol. There's a nice combination of propofol and remifentanil that they use for non-paralytic intubations, which will make the child apneic and relaxed enough for you to do. And then if you want to combine ketamine and propofol, it's not the ketofol dose. It's full dose of both of them if you're going to try and do an intubation with it. And then the flat-out naked intubation, which is just, somebody hold this kid's head still and I'm going to, ram this blade down them. All right. If you use rocuronium and the kid is not exhausted, so say it's a trauma patient and you want to put them down, you do what's called a timed intubation. And this is a reversal. If you use succinylcholine and Etomidate, you give the Etomidate first, then you give the succinylcholine. In rocuronium, you do it backwards. You give the rocuronium first, wait about 15 seconds, give your induction agent, and then at about 25 seconds from when you begin is when you actually you'll be able to put your laryngoscope in. I don't know where this concept came from there, but God forbid, once you've given them the paralytic, you've got to stuff the laryngoscope down and put the tube in within seconds and not bag them up. If you've got a kid that's struggling and they're fatigued and whatnot, there's nothing wrong with paralyzing them, sedating them, and bagging them up till they've got, their CO2 down real low, their oxygen up real high. Then go ahead and do your procedure. You watch the operating room, they do it all the time. Cricoid manipulation, if you've got a real small child, they say you can do this with your finger. I've watched a neonatologist do it. Either I have small hands or a small finger, but I can't do it. I'm a fan of this technique. Don't manipulate the cricopharynx yourself, because if you put it into just the right view, you have to have somebody hand it off to somebody to hold it there. You're better off having them start with their hand on the cricopharyngeal area. You put your hand on top of theirs, move their hand to where you want it to be, and then you just let go and have them hold it there. All right, this is the way you're supposed to do a pediatric intubation. And I say supposed to because this is the way I've always done it, but times change. Put the blade in slowly, okay? You're very anxious. I mean, this is my particular approach, is take the blade, bury it as far as you can, look in there and go, yeah, that's the pylorus. Okay. And it's easy to do. You're adrenaline's running and everything else. So go in slowly and visualize the epiglottis. And since I've developed this, take your time, go in. It makes it a lot easier. I'm a big fan of pushing the tongue all the way to the left side. There's studies that say it doesn't make any difference going straight down the middle or pushing the tongue to the left side. Your equal success rate. I'm a big fan of pushing it to the left side. Okay. Tip the blade down, pick up the tip of the epiglottis. Okay. Look through, visualize the cords, and then put your tube in. Okay. I mean, realistically, has anybody ever seen the cords that well in a little kid? It's like, first of all, your hand's shaking so much, so it's hard to get them in view. But this is, I think they painted this picture. But at any rate, this is an intubation. This is from Rich Levitan's AirCam. And it's really worth purchasing these videos. So you're looking back there. There's the epiglottis. Tip down, pick up the epiglottis. Take your time, lift. There's the cords. Now, this is something that's really cool. Watch this. They pull the lip back. This is hugely helpful, okay? And then you put the cord in. I have somebody assigned. The person who's going to do the cricoid or hand me the laryngoscope is the person who's also going to pull that lip back as soon as I start. How many times have you seen that where you've got the tube in and you've got the lip that's sticking in your way and you can't see anything, you pull it back? The other thing is, and a neurosurgeon taught me this once, he said when they would go in and clip these aneurysms, what they were taught was as soon as you saw the aneurysm, you never took your eyes off of it and you just reached your hand out and they gave you the instrument you needed. Because if it started bleeding, all of a sudden something burst and it started bleeding, you knew where you were going to put the instrument because you lost your visualization on it. Same thing with this. When you put the laryngoscope in, you tell who's ever assisting you. When I put my hand out, you put the tube in my hand. I don't want to look away. Because you've got everything positioned just right, and if you look away, your hand's going to move. But then you come back, and now you've got to re-identify things. Once you see those cords, you never look away from it. Put your hand out. They feed you the tube. Now, I learned this a couple months ago. A guy at a conference, and then Richie Cantor told me, oh yeah, I do this all the time. And it's like, well, why the hell didn't you tell me this? There's a ligament that goes between the hyoid bone and the epiglottis, okay? And if you look at that ligament, you've all seen it 100 times. You've easily seen it 100 times. You do the intubation, there's a ligament there, okay? What do you think happens if you take your laryngoscope and instead of picking up the epiglottis, because to be honest with you, in an infant, you go in, you see the epiglottis, you dip your laryngoscope down to pick it up. The whole glottis is only this big, so it's real easy to slip behind and pick up the whole glottis. So you're looking at the esophagus, and then when you try and back out just enough to let the glottis fall down, you come back too far, and then the epiglottis falls down again. We've all had that happen. If you push the blade forward into that ligament, what do you think happens to the epiglottis? It pulls up, right? So now they're not picking the epiglottis up at all. All they did is push the laryngoscope forward. And you can see it pop up. Josh Nagler from Harvard taught me this. And it was like, well, that's pretty neat. Here's another one. Watch. And this is one where you'll see the ligament. And watch what happens. It pops right up into view. I mean, if you saw a view of the cords like that, I mean, your heart would go pitter-patter. This is something to remember. So if you're going in and you can't pick up the epiglottis, just push straight forward and the whole thing will pop up into view. If you want, obviously you do a lot more adult intubations than children's intubations. Try it on the next adult. You're used to using a curved blade, you slip it into the vallecula. Just take the blade and push it forward a little bit and watch what happens. It's pretty impressive. And I think a lot of the times when we're doing adult intubations with a curved blade, that's actually what we're doing, is pushing on that ligament, and that's pulling the epiglottis up for us. All right. There are rescue techniques. You're not going to get every intubation. You can always back off and bag the kid. Kids are easier to bag than adults, and I don't know why. Supraglottic airways. We talked about the transtracheal jet ventilator. These are these kits. You can buy a kit with every size laryngeal mask airway, supraglottic airway, for $100. So it's well worth getting in your department. What you want to do is you take and you slide it along the roof of the mouth just like you would any other LMA. In terms of ventilators, once you've got the child intubated, you have to put them on a ventilator. And one of the problems is the tubing will distend. And if you try and do the child's ventilation, if they're under like 10 kilograms, with a volume cycle ventilator, it's going to put in the amount of volume you tell it, and all that volume is going to do is distend the tubes and let it contract. So instead of ventilating the child, it's just going to ventilate the tubing. So what you have to do is you have to do it by pressure. So you tell the ventilator, I want you to give this much pressure, and then stop and let the kid exhale and do it again. And the way that works is real simple. Pressure cycle ventilators, it's for kids less than 10 kilograms, this is what you're going to use. If you're in a very sophisticated PICU with rigid tubing, you can do them volume cycle, but this is what we're pretty much stuck with. Basically, you tell the respiratory therapist, set the peak pressure to 25. It's just an easy number to remember. That's the pressure, so what it'll do is it'll deliver the gas until it hits 25, it'll cut off. Deliver the gas at 25. If you used the Neo-T to ventilate the kid, to do the intubation, do the initial ventilations on them, you know exactly what pressure you want by what's going up and down. You've got an end-tidal capnometer on them, so you know where their CO2 is. It's real easy to set your pressures on these kids. Put them in about 5 of PEEP, start them at 100%, and then rapidly dial it down. We have a tendency to put kids at 100, and adults at 100% and leave them there. Just dial it down until their O2 sats drop to 95% and then stop there. Sedation, whatever your favorite is. Ketamine, you can just keep bolusing them every hour or so. Propofol, you can put them on a drip short term. Remifentanil, you can give as an infusion and works very well for these kids. And then dexmedetomidine is just now coming off of patent, so you'll be seeing a lot more of that being used. So you put it all together. You're going to intubate this child. Your checklist is completed. You oxygenate them maximally as you can. If you're going to use succinylcholine or rocuronium, whichever pathway you pick, you give them your paralytic, your induction agent. You've got your intubating conditions. They're relaxed. They're oxygenated. You put your laryngoscope in, put it in, ET tube goes in, capnometer goes on immediately. You confirm where they are and do the sedation. I can't emphasize enough that your experience with adults translates to kids. I was doing a course in July in Philadelphia with it was a pediatric board review course. And the guy from Harvard was doing the Airway talk. That's where I learned this technique. And his comment was fascinating. He's talking about, you're going to be scared, and don't worry about it. He goes, but make sure you have all your equipment. He goes, and if you work in a pediatric emergency department and that happens to have an adult emergency, and I said general emergency department, not adult, a general emergency department next to it, go get the general ED doc because they're much better at managing the airway than you are. I thought, well, finally somebody realized it. And it's the truth. We see it all the time. They always say, hey, can you come here and help me a little bit? We had, one of our younger docs had a kid, 18-month-old, down the spiraling, respiratory distress airway, finally winds up intubating the kid, does a beautiful job. She's, everything does perfect. The whole team came together perfect. Intubates the kid, and now we got to transfer the kid because we don't have a PICU. So we stabilize and transfer, which is, what's happening everywhere because they're shipping all the kids to one place. And, the nurses and her decided we don't want this tube to come out during transport. So they, put a lot of tape, they sutured it in with wire, they did a whole bunch of stuff. And they shipped the kid off to the PICU. They get a call, they call this is nighttime when this happens. So about 5 in the morning they call to see how the kid's doing, and they say the kid passed away. They said, What do you mean the kid passed away? They said, well, when he got here, he coughed the tube out. It's like, no, the kid didn't cough the tube out. That's impossible. They were, they had enough ketamine to last them until they were a teenager. They didn't cough the tube out. Well, it turned out that respiratory decided they were going to tape it in better. They accidentally extubated the kid. These things happen. No big deal. They didn't have an emergency physician they didn't call the ER to get the emergency physician. They called anesthesia, who was uncomfortable, wouldn't paralyze the kid to put the tube back in, never got the tube back in, and then the kid passed. So when you look at that, it's like, how come the ER, who are supposed to not be able to handle this stuff, managed it perfectly, and the tertiary care center that was supposed to be experts on it had all the trouble? So don't let anybody convince you that you are not the experts in pediatric airway management. You are. All right. So next time this kid comes in, just remember, you got this. You don't need anybody else to tell you that. All right. Go get him.